Most people think high blood pressure means headaches, dizziness, feeling unwell. So if you feel fine, you're fine, right? Wrong. I've opened the chests of patients who felt perfectly healthy the week before their stroke. It happens far more often than you think. Men and women who walk their dogs, cook dinner, laugh with their grandchildren just days before. No warnings, no symptoms, nothing to suggest what was coming. Blood pressure doesn't send you a warning before it attacks, especially not at night, especially not after 60. Here's the core problem with how blood pressure gets measured. Your doctor checks it once during an office visit for about 30 seconds. 30 seconds out of 86,400 seconds in a day. That snapshot is what your entire treatment approach is based on. And for most of those seconds, you're asleep. And that's exactly where things get very interesting. Under normal conditions, your blood pressure does something remarkable during sleep. It drops by about 10 to 20% every single night. We call this the dipping pattern. It's not optional. It's your cardiovascular system performing essential overnight maintenance and repair work. Your heart repairs itself. Your blood vessels recover. Your kidneys process waste. Every one of these processes depends on that nighttime pressure drop. But here's what changes after 60. Your arteries gradually stiffen. Your blood vessels lose their elasticity. The whole system begins running differently. And your autonomic nervous system, the one controlling that nighttime pressure drop, starts losing its rhythm. The signals get weaker and less reliable. For millions of people over 65, that nighttime dip simply stops happening. The pressure stays elevated or rises even higher while they sleep. You wake up tired, your head feels foggy, you think, I just didn't sleep well. But the real explanation is something quite different, and most doctors never measure it because they're only looking at that 30-second snapshot, not the full 8-hour picture. Not even close. Let me give you a real example. A patient comes in, blood pressure 120/78, completely normal, textbook perfect. I send him home with a 24-hour monitor. He goes about his normal day and falls asleep around 11 that night. By 2 in the morning, his pressure is 164/102 while he sleeps, completely unaware. That's not a mild elevation, that's a hypertensive crisis happening while he sleeps peacefully, with absolutely no idea it's occurring. How does this happen? There are 3 main reasons, and each one is far more common after 60 than most people realize. First, his medication was taken in the morning. By midnight, its protective effect has almost completely worn off. The coverage gap is real. Second, his stress hormones, cortisol and adrenaline, aren't following their normal nighttime rhythm. Instead of dropping, they spike while he sleeps. Third, his sleep is fragmented. Every brief awakening, even when he doesn't remember, triggers a sympathetic response and a pressure surge. And this happens night after night, not occasionally, every single night. The same surge, the same silent accumulating damage year after year. The damage accumulates silently in the walls of his arteries, in the tiny vessels of his kidneys, in the tissue behind his eyes. Month after month without a single symptom to send him to seek help. The body compensates quietly, until one day it can't. We have a clinical name for people whose nighttime pressure doesn't drop. We call them non-dippers. More than 50% of adults over 65 are non-dippers. More than half. Not a rare edge case, the majority. Half the people in that age group carrying the hidden cardiovascular risk that their morning blood pressure readings will never capture. Non-dippers carry a cardiovascular mortality risk 3 times higher than dippers with identical daytime numbers, 3 times higher risk with the same daytime reading, the same medication, the same diet, just from what happens during those 8 hours of sleep. And then there's an even more dangerous pattern, reverse dippers, people whose pressure actually rises during sleep, higher at night than during the day. For reverse dippers, stroke risk increases by a factor of 4 or 5, and they feel completely fine during a standard office visit. Standard office visits catch none of this. None. Zero. That is the diagnostic gap we need to close. Now let's talk about the things already in your home that may be silently making your nighttime pressure worse. You'll be genuinely surprised. The first one is licorice root. It sounds harmless. It's an herbal tea. Natural, calming before bed. Many people love it. But licorice root contains a compound that blocks a specific enzyme in your kidneys. Without that enzyme, cortisol builds up in your bloodstream. Elevated cortisol at night means your pressure surges. You don't feel it happening. You just wake up exhausted with no obvious explanation. Check the label of your evening tea. Look for licorice root, also listed as glycerizer, sweet root, or natural flavoring, or buried inside natural flavoring and herbal blends. The second hidden factor is alcohol, specifically evening alcohol. The initial sedative effect of alcohol does temporarily lower blood pressure. That part is real. But 3 to 4 hours later, something else begins. Right in the deepest stage of sleep, there's a rebound spike. Your sympathetic nervous system overcorrects. The pressure surges sharply upward. Your cortisol surges. Your blood pressure can reach its highest point of the entire 24-hour cycle at 3 in the morning. The third hidden factor is grapefruit juice, specifically when taken alongside amlodipine or other calcium channel blockers you may be prescribed. Grapefruit blocks the liver enzyme that breaks down these medications. The drug accumulates. What was designed to be gradual becomes dangerously prolonged. That unpredictability is especially dangerous at night when there's no monitoring, no one to catch symptoms, and no easy way to respond. So how do you actually find out what your nighttime pressure is doing? There is a test specifically designed for exactly this question. It's called ambulatory blood pressure monitoring. You wear a small cuff for 24 hours while living completely normally. It takes readings automatically every 30 minutes, day and night. This is the gold standard for identifying non-dipping patterns, the only way to see your true nighttime blood pressure profile. Yet most people over 65 have never worn one. Ask for it by name at your next appointment. If you don't specifically request it, it will almost certainly never be ordered. The second test is urine microalbumin. This measures tiny amounts of a protein called albumin that leaks into your urine when kidneys are under stress. Microalbumin is one of the earliest detectable signs of organ damage from sustained high pressure, appearing years before kidney function visibly declines. It's a warning signal while there is still time to change the course before damage becomes permanent, before it shows up on any other test. The third test is oxidized LDL. You know LDL as the so-called bad cholesterol. Oxidized LDL is what happens when that cholesterol is damaged by free radicals, essentially rusted cholesterol, far more destructive to arterial walls. Standard cholesterol panels don't measure it, but it's a direct marker of arterial wall damage, exactly what sustained nighttime hypertension accelerates. These three tests together, ambulatory blood pressure monitoring, urine microalbumin, and oxidized LDL, give you a clinical picture that no standard checkup ever provides. Affordable, widely available, and almost never ordered unless you ask for them specifically by name at your next appointment. Now let's talk about solutions, starting with the most overlooked one, the timing of when you take your existing blood pressure medications. Most antihypertensives are taken in the morning. That's the convention. That's the habit. But is it actually optimal for protecting you at night? The protective effect of most blood pressure medications peaks within a few hours of taking them, then gradually and steadily fades throughout the day. If you take your pill at 7 in the morning, by midnight its protective window has significantly diminished, right when you need it most. There was a landmark study addressing this directly, the Hagia chronotherapy trial. 20,000 patients, 6 years of follow-up, one of the largest ever conducted. Researchers compared patients taking their medications in the morning against those taking the same medications at bedtime. Everything else held equal. The results were remarkable. The bedtime group showed nearly 50% lower rates of heart attack, stroke, and cardiovascular death. Nearly 50% reduction from simply changing when the medication was taken. Same drugs, same doses, dramatically different outcomes. Do not change your medication schedule on your own. Talk to your doctor first. This step requires a direct conversation. Some medications genuinely should not be taken at bedtime, diuretics especially. Your doctor needs to review your specific case before any change is made, but the conversation is absolutely worth having. One question at your next appointment could change the entire approach. It takes 30 seconds to ask. Let me tell you about something with genuine clinical evidence behind it: hibiscus tea, specifically the dry flowers of Hibiscus subdurifa. Hibiscus contains compounds called anthocyanins, the same molecules responsible for the vivid, deep color in blueberries, pomegranates, and red cabbage. Anthocyanins are powerful antioxidants. They neutralize free radicals, the molecules that damage arterial walls and directly contribute to oxidized LDL. Hibiscus also inhibits ACE, the angiotensin-converting enzyme, the same enzyme that a major class of blood pressure medications target. Multiple clinical trials have shown consistent blood pressure reductions in patients with mild to moderate hypertension who drink hibiscus tea daily. We're talking reductions of 8 to 14 millimeters of mercury in systolic pressure in patients not on medications. That is clinically meaningful. Preparation matters. Weak hibiscus tea has minimal therapeutic effect. Use 10 grams of dried hibiscus flowers, not tea bags, not blends, actual dried flowers. Water at 90 degrees Celsius, steep for 10 to 15 minutes, not 5, not 7. The extraction time matters for the active compounds to fully release. The color when properly brewed should be deep burgundy, almost like dark wine. If it looks pale pink, steep it much longer. 3 cups per day is the dose studied in clinical literature.